Good evening, dear doctors. I'm Dr. Harshvi Singh Mali. I'm the Head of Medical Affairs for Oncology at Merck India. I welcome you all for today's educational session, which is under the Insight of Guide, which is GU Insight and Data Exchange. For today, we'll be looking at a very interesting topic of, is it time to look forward to, sorry, Nirav, the last slide, please. Is it time to look forward favorably at the first-line immunotherapy containing combinations in all IMDC risk groups? Next slide, Nirav. This is the agenda that we'll be having for today. We'll be having our chairperson delivering his context setting, followed by an international expert, Dr. Ricky Fraser, who's actually joining us from ASCO GU today, giving his keynote lecture, followed by an case discussion and an interesting panel discussion, which will be led by Dr. Chandrakant, sir. Next slide. It is our privilege to have Dr. Professor Sudhir Kumar Rawal, sir, as the chairperson for today's session. Dr. Rawal, who actually needs no introduction, he is the medical director and chief of genitourinary uro-oncology services at Rajiv Gandhi Cancer Institute in Delhi. A pioneer in his field, he has a vast experience of close to 3 decades in onco surgery. He is an internationally recognized expert in genitourinary oncology with a special interest in robotic surgery. He has also innovated the Pitcher's plot ileal neobladder, which has found display in leading urology publications. Dr. Rawal is also the first surgeon who has done more than 1,000 robotic surgery in Eurasia. Without further ado, again, it's our privilege to have you as the chairperson. I may please invite you for your context setting session. Next slide, Nirav.
Thank you, Mahi, and it's my pleasure to be here and set the context. Today's speaker is Dr. Ricky Fraser. He is from Wales, Cardiff. I remember Wales recently. I spoke in the Wales Urology Society on telesurgery because we have pioneered telesurgery in India, telerobotic surgery. So they invited me for giving a talk. It was online talk from Delhi, and but coming to the meeting today, the objectives are to discuss the treatment options for patients with advanced renal cell carcinoma, treatment factors important for individualizing therapies for patients, as we see many times in our practice. A case presentation will be done and panel discussion to get more insight and clinical practice consideration. And it is time to look, the topic is, as already been told, that it's time to look favorably at first line immunotherapy containing combination in all IMDC group. So I'd like to invite Dr. Ricky Fraser, please. Dr. Ricky Fraser, okay, that slide was there. Anyway, Dr. Fraser, you can speak. You already take care of this thing. Yeah, shall I introduce him? So he is a consultant medical oncologist specializing in renal cancer immunotherapy and melanoma and non-melanoma skin cancer, clinical lead for acute oncology assessment unit and co-lead for the Southeast Wales Immunotherapy Toxicity Services. He is Deputy CEO Immuno-Oncology Clinical Network and HEIW faculty lead for Wellandire Cancer Center and Royal College of Physicians College tutor. Honorary lecturer, Cardiff University, and his medical education leaders in UK, Wales. He is also expert in infection prevention and control lead. So Dr. Fraser, please go ahead.
Thank you. My pleasure to be here. I'll just start sharing my slides. One second. Is that coming through with the notes or is it coming through without the notes?
Yes, we can see the notes.
Okay. Give me 2 seconds. Let me just share the other one. Just 2 seconds.
We can see in the full screen mode now. Thank you.
Okay, perfect.
Sorry, it went away.
Yeah, no, that's fine. Give me 2 seconds. I'm just going to
Sure,
show
no
it in a
worries.
slightly different way.
And in the meantime, that Dr. Fraser sets up his time, a really pleasure to have Dr. Fraser here because he's joining us actually from ASCO-GU. So quite early in the morning that you're joining in. Thank you so much. And we are looking forward to this engaging lecture from your side.
Great. Perfect. Okay. Hopefully that's coming through.
Yes, I can confirm it. Thank you.
Perfect. Great. So look, it's great to be here. It's great to be joining you from GU ASCO. There's some, I think, interesting data being shown in the renal space today. I'm very happy to talk through that. I've had a lovely introduction, so I do a few things, including renal, and I chair a podcast called the ImmunoBuddies, which again, it'd be great if you want to check it out and have a little look at that. I've got some advisory and speaking fees, but hopefully you can see that I work with a lot of companies in the renal space. And so what I'm going to try and do today is be as objective as I can be around what I'm doing in real life. Now, there's some slides, but you know the real value of this meeting will inevitably come from the discussion, the case. So some slide I'm going to allude to relatively quickly, and it's really just a scaffold for what I think is going to be a fantastic discussion with your colleagues locally, and there's some really fantastic experts on that panel. Just to set the scene, I think it's important to remember that a lot of patients still don't get beyond the frontline space, and we all sit in meetings and think that we're doing really well and that 80 or 90% of our patients get second line or third line therapies. But if you look across the world, and I was at a meeting last night where it's somewhere between 60% and 30%, so something in that range of patients who, even once you censor for the patients that are doing really well on frontline, there's a significant proportion who after frontline deteriorate and never get another treatment. And I think that's really important because it contextualizes why I think we need to be using our best treatments first. And the idea that you can save immunotherapy for later isn't the reality. And I'm going to show some data around that as we go through today. Now, we'll be familiar with this, and I'm not going to spend long talking about it. It's been a journey from TKIs to IO-TKIs to IO-IO. And really, in that frontline space, we've got a lot of options, which, if you look at them just on first glance, it all looks about the same. So response rates all look similar, somewhere between 55 and 70%. PFSs are somewhere between 12 and 24 months. And so it looks like all the data sets are much of a muchness. We shouldn't be doing cross-trial comparisons, but what we should be doing is looking at the individual trials, looking at the patients, the subgroups, and therefore using the data to decide how we should approach the patient in front of us. We're going to talk through some of these data sets today, but again, I'm not going to try and do lots and lots of data and hazard ratios. What I'm going to try and do is a slightly more finessed conversation around how I use the data and the baseline characteristics to help me choose what to do in that frontline space. It's important to think about the patient, and there's clearly certain disease factors that are going to be important. So, for example, we know that sarcomatoid patients do well with immunotherapy. We know that the prior nephrectomy rate will impact your chances of getting a complete survival. It's virtually impossible to get a radiological complete response if you've still got the kidney in. And so therefore it's important that we look at the data through that lens. Equally, we know that if you look across the subgroups, most favorable risk patients will do better in terms of response rate and PFS than intermediate and poor. And so in data sets where there's more favorable risk patients, I would expect there to be an uplift in the data, even if there's no appreciable difference between the different treatments. And so again, that's going to be an important context that we look at. Now, I spend my life managing IO toxicities. And so again, I'm really interested in, what's my chance of getting pneumonitis? What's my chance of getting a grade 3 or 4 life-threatening toxicity? And how am I going to differentiate an IO versus a TKI toxicity? If I've got someone on cabozantinib, it's a 100-hour half-life. That's very different in terms of the time for lenvatinib, which is 28 hours, or exitinib, which is 4 to 6. So again, half-lives of TKIs are really important when we think about differentiating between IO and TKI. And so if everything else is even, I'd want a TKI that's got a short half-life, which means that if I stop the treatment, I can expect the toxicity to resolve. And if the toxicity doesn't resolve, it's guiding me towards that being an immunotherapy toxicity. So I know this data will be familiar to many of you, so I'm not going to talk my way through it. There's a few things I just want to bring out. It's about 900 patients, Javelin Renal 101, Axiavi versus sunitinib, sunitinib being the standard of care across all of the 5 main frontline trials. Endpoints as we'd expect. Primarily, initially it was going to be in PD-L1, but in the end, in essence, we're looking at the overall population. Importantly, though, one of the things that patients focus on is durability. And the nice thing about this data set is we've got the longest follow-up of any IO-TKI. And so, again, clear studies never going to go past 4 years of follow-up. They're not collecting data anymore. And so if we want to look at that durability, I think the Javelin Renal 101 gives us that opportunity. Now, this slide's really important. If you look at the characteristics of patients in Javelin Renal 101, there was only 20% of patients who've got favorable risk disease. If you compare that to something like Checkmate 9EI, so the Cabo-Nivo, it's 23%. If you look at the LEMPEM clear data, which often people say, that's got the best response rate, that's got the best PFS, they had 31% of favorable risk patients. And so by definition, I would expect there to be better response rates. I'd expect there to be better PFS because they've got a better group of patients in the trial. And so again, when we look at the data and we see 55% response rates or 60% response rates, we need to look at that through the context of the patients in the trial. And if there had been 31% favorable risk in Javelin, my personal opinion is we would have seen response rates of 70 or 75% across all the IMDC risk groups. So it's important not to do cross-trial comparisons, but it is important to understand the patients that were in the trial. So this is the data. So you'll know this data almost certainly. So PFS improved against sunitinib about 14 months. And for context, again, if we think about Checkmate 9ER or Pembro-Axi, PFSs are 15, 16 months. But again, this is on the context of a group of patients that weren't particularly favorable. And so we really do need to have a look at that favorable risk group to understand what the response rates are and the PFS within the favorable risk when we're comparing the different combinations. This was the overall survival data, and this is the bit that's received most criticism, with people saying, well, it didn't reach overall survival benefit across all the IMDC risk groups. Again, I think we need to look at the favorable risk group as a separate thing, and that's what we're going to do. And again, just some reassuring data, I think. So if you look at real world studies, and we all know that in real world studies, patients tend not to do as well. If you look at the PFS in the Japanese study, PFS 17 months. And actually, if you compare that to the Cabo-Nivo, Checkmate 9ER, we see 16.5 months. If you compare it to Keynote 426, you're getting 15 months. So in the real world, that's, I think, impressive data that we're seeing. And I'm going to come back to the UK ROC data a little bit later. Now, again, this is important. So what does toxicity look like Well, it's about 15% of patients who will get a grade 3 or 4 toxicity with a combination. If you think about Ipi/Nivo, that's a sort of 40% grade 3/4 toxicity rate. So I think, tolerability is something that I'm seeing with this combination. And when we look at the side effects, and I'll talk about these a little bit more later, and very happy to talk about toxicity, most of the toxicity that we're seeing is driven by TKI. And so actually, if you look at this plot, you're actually seeing similar bars on each of the aspects, sunitinib and the combo, and that's because most of it is TKI-driven toxicity, which again, for me, half-life becomes really important. And quality of life data still confuses me. I struggle to understand what it means, but even I can see that the curves are going in the right direction. And so people are feeling better. And so if you're looking at the sunitinib, you have to bear in mind that the sunitinib data was done in the 2-week break when patients often feel their best. And so again, interesting that still, if you look at it, the data's comparable, but that's even in the off period for sunitinib, not the period where they're getting most toxicity. So how do we decide what to do? How do I decide in the real world what to do with favorable risk patients? And this is essentially what I look like in clinic. I look a little bit confused. I'm thinking about single agent. I'm thinking about active surveillance, and I'm thinking about all those different combinations. And so I created this a little while ago. And again, if there's only 2 pictures of any of the slides you're going to take, this is probably one, and then there'll be another one a little bit later. And this is how I think about what's the right treatment option for the patient. What's the priorities of the patient? What does the response rate and data look like? How is it in terms of dosing? Is it a dosing that I understand? Is it a dosing that's easy to do, both in terms of titrating up and then titrating back down? And what am I getting in terms of the quality of life for the patient in front of me? And so when it comes to the favorable risk group, we're really coming down to, am I going to give an IO-TKI combo, or am I going to give TKI alone? I'm personally not giving combination IO, because with a response rate of about 30%, I don't feel like I can justify it. I accept that there are some patients who will do well, get a durability, but there are a significant proportion of patients who won't get a response at all. And when I speak to patients in clinic, what do they say to me? Well, they want things to respond quickly. They want their first scan not to be seeing progression, and they want their best chance of disease control. So that's what I hear in the real world in clinic. And then I think this slide is really nice. So this is data that was presented at ASCO in Chicago 18 months ago. And actually what patients tell me in clinic is what patients are telling us in worldwide consensus, which is in essence that patients really want to be getting this durability. They want improved quality of life. And they want the chance of getting complete responses and durability. And again, if we think about those goals, IO-TKI has better control, has more chance of durability, has a comparable quality of life, and has more reduction in tumors. And so that's how I'm deciding between TKI and IO-TKI. I'm not going to talk much about poor risk, but I think we can maybe pick it up in the discussion later. Again, we know that poor risk tend to be more immunogenic. We know that's not an exact science, but we know that poor risk do tend to be more immunogenic. But actually, there's some really nice data in the risk group in Javelin 101 in the poor risk patients. So if you're looking at hazard ratios, overall survival, 0.63, I think that's worth knowing that Javelin 101, the axivalimab can be a good option for poor risk. And similarly, if you look at this slide, again, if you're looking at PFS, if you're looking at OS, hazard ratios are 0.58, 0.48. So I think this can be a very good option for your favorable risk, but I also think it's a very good choice for poor risk in the right patients. So to kind of simplify, this is the 2 questions I think we're asking ourselves. Are we going to give an IO or a TKI? I think for the data we've shown, it makes sense to try and give an IO TKI. If I do give single agent TKI for frailer older patients or those that I don't want to give IO, I tend to use tivozanib because it's the drug that I think is quite specific for the VEGF pathway. But if we're going to use IO TKI, then basically we're going to have to work out for the favorable risk, what of those 4 combinations are we going to choose? So this is some real world data that we did in the UK, partly because we used to sit in meetings debating this endlessly and ad nauseum boring ourselves to death, talking about the fact that all of us were doing great. We all knew what the right answer was. And so we pulled 17 centres together in the UK, 1,319 patients. And a couple of messages in the key demographics. So less patients have had a prior nephrectomy, so about half. And so that's important. So we're not expecting to see as many responses or complete responses. And actually, again, if you look at this comparable to what we see in the real world, about 80% were clear cell, about 2/3, just over, were male, and a good distribution between favorable, intermediate, and poor. And if we look at the real world data in the UK, actually what we're seeing in real life, so the original curve is some data that was done back in 2016, and this is our updated data. And actually it confirms what we thought, that actually 40% of patients, even when you're censoring for the patients that are doing well, will not get a second line of therapy. And so for me, that take-home message is really straightforward. Use your best treatment first, otherwise risk not using it at all. And then if we look at the drop-off rates, I think that's really important in terms of thinking about the drop-off rates, even in the favorable risk group. Sorry, give me 2 seconds. This is my wake-up call that's 2 hours late. So this is the drop-off rates between the different groups. And so this is in the favorable risk group. And if we're looking at drop-off rates, even in the favorable risk, where we assume that patients are all going to do really well, there's a significant drop-off rate in patients who are receiving who get favorable risk disease. And so actually 1/3 of patients, even in favorable risk, don't get a second line therapy. So the idea that everyone in favorable risk will get, immunotherapy if they don't get it front line just isn't the case. And this, I think, is a really, really important message, that within those favorable risk patients, if you don't get IO in the front line, half of patients will die without receiving immunotherapy at any point. And that's really important, because I think it's a travesty for renal cancer if you die never having had immunotherapy, and therefore never really having the chance of potential durable response. I'm not allowed to use the word cure in these kind of meetings, but that chance of a durability. And frankly, who cares what I think? But this is what the ASCO guidance think, which I think is quite useful, essentially saying that IO TKI should be considered across all the different risk groups. So this is our real world data. This is a big group of patients, just under 300 patients, 294, of which 95% of those patients in the IO TKI received axiavelamab. And in the real world data set, we do see an overall survival advantage of using Axiavi over single agent TKI with confidence intervals less than 1. And so actually what this tells me is, in the real world, accepting this is retrospective data, but it's in essence all we've got and all we're likely to get in terms of big data sets, certainly in the UK, we do see an overall survival benefit for Axiavi over a TKI. And so again, I think this is really reassuring data when we're deciding what to do. And again, I've told you about the drop-off rate, and we do see that drop-off rate even in the favorable risk. And again, just reminding you about the fact that 50% of patients, if they don't get it frontline, won't get IO at all. And so that, again, just reminds me that I need to give my best treatment first. So if you're going to give IO-TKI, the next question is going to be, well, what TKI to use? And for the basis of the fact that it's much more VEGF targeted and therefore there's less off-target side effects, my preference is to try and give exitinib. And similarly, when you look at half-lives and therefore how quickly you can stop a drug and therefore see resolution of toxicity, exitinib's got the shortest half-life by a significant distance. And therefore, actually, I find exitinib really easy to manipulate in terms of starting with 5, going to 7, going up to 10, back to 7, 5, 3, 2, 1, if needed. And so I think it's a really adaptable drug. Lenvatinib, for example, start at 20, you then go to 14 and then to 10, but then the second line trial, they use 14 and 18. And so I find that a trickier drug to manipulate. Again, just a reminder that, if we look at those different combinations, we've also got a different target in terms of Axiavi working on PDL1, anti-PD1 for the others. And there is definitely a school of thought where people say, actually, PD1 does better across the 3 risk groups. I think PDL1 does better in the favorable risk. And again, who cares what I think? What does the data tell us? So if we look at the data of Axiavi versus Axipembro, therefore the only difference being PD1 versus PDL1, and we focus on the efficacy data, this isn't what I think, this is what the data tells us. So if you look at overall response rates in the favorable risk patients and compare them across the different trials, there's no doubt that you're seeing a better response rate in the Axiavi group than you are in the other different groups. And so again, if we follow data, the best responses that we see is with Axiavi compared to the other different IO-TKIs and IO-IO. And then again, if we look at survival, which is what patients are interested, we get the best hazard ratio with the Javelin Renal 101 Axiavi than we do with any other data sets. In fact, if you look at Axipembro, the hazard ratio is negative. If you look at 9ER, it's negative, yet we've got a hazard ratio of 0.73 when it comes to Axiavi. And so again, I find that really reassuring data. And then why do I think it's better in the favorable risk patients? I think it comes down to NK cells, and I think we're still working out what natural killer cells do. But in the PDL1 agents, there's definitely, I think, more recruitment of NK cells, and I think that's why we're getting more involvement of the immune response in favorable risk with Axiavi than we are in the others. And so just to flip back to the previous slide, that's why I think we're getting better survival and better response rates with that combo compared to all the other combos. And then in terms of toxicity, well, again, this isn't what I think. This is the data in the trials. It's got a very low discontinuation rate in terms of the Javelin 101. It's got the lowest discontinuation rate. In terms of steroid use, it's better than all the other drugs. And if you look at the pneumonitis rate, it's favorable compared to all the others. And so it's winning in the favorable risk on data for OS, data for response rate, and data for adverse events. And so if you're using the data in the way that we all argue we do, the data tells us that the best combination in favorable risk is to use Axiavi. That's not what I think. That's what the data is telling us. And again, it's advantageous to have a half-life of 4 to 6 hours because it means that if we stop the drug, pretty quickly those toxicities are going to resolve. And if they don't resolve, we need to think about the fact that it might be an IO toxicity. So that's how I approach it in the real world. I think about a favorable risk patient. I'm deciding between IO-TKI and TKI. And based on the drop-off rates and the fact they may never get IO otherwise, I'm going down the IO-TKI route. And then I'm looking at the data. So I'm not just saying, well, I think Axiavi isn't as good as the others. I'm looking at the favorable risk data. It's got the best OS, it's got the best response rate, and it's got the best toxicity profile. And so I think if you're following the data, that's actually the drug we should be prescribing. Yes, you have to give it every 2 weeks. I get that. But ultimately, if you look at what patients are interested in, they're interested in durability, they're interested in being alive, they're interested in quality of life. And I think Axiavi is offering those. So just to summarize, and by sheer amazement, I'm almost on time. We've got favorable risk disease. I think we've got really good data. I think there is some poor risk data for Axiavi, which is worth thinking about. I think really important in the real world data, we're seeing a third of patients are still not getting a second line treatment after progression. Half of those patients who progressed are never seeing immunotherapy. I think that's wrong. And we are seeing better data with the Axiavi in terms of quality of life and toxicity profiles. Just to say, I'm very happy for you to take a photo of this. If any of you are interested, it'd be great if you want to follow me on social media. Again, if you're interested, there's lots of education and around IOTKI. Again, there's 130 podcasts available. And again, if anyone's interested, I run a meeting the first Thursday of every month, 1 o'clock UK time, which should be a decent time for you. I think it'll be early evening. Again, it's completely free to join. It's all on Teams and you'd be very welcome to join. Just drop me an email and I can put you on the list. And again, if anyone's more interested in IO more generally, we're now extended the Immuno-Oncology Clinical Network, which we set up a year ago, to all international doctors. And so again, if you want to join that, just click on the website or scan any of the QR codes and we'd be delighted to connect with you. So I will hand over to my colleagues and we'll go from there.
Thank you so much, Dr. Fraser, for that insightful lecture. And with your permission, also, what we will also request if the last slide that you showed of the educational resources and the others, because they are close to 80 live audience that we have right now. After the meeting, we will also share that with the live audience also, because they will find it also interesting, maybe to join some of these forums. So we'll request your permission for that. Thank you. Great. Dr. Fraser, Neerav, if you can go back into the slides, please. Thank you. So after this insightful lecture by Dr. Fraser, we will now move into the second part of the session, which is a case study being presented by Dr. Alok Gupta, sir. Neerav, next slide. Yes, Dr. Alok Gupta, sir, is currently the director, senior director and head medical oncology at Max Super Speciality Hospital in Lucknow, and he was previously associated with Medanta Hospital in Lucknow. And while there is, he has also completed his TM at Tata Memorial Hospital in which is also the education piece. Dr. Alok Gupta, sir, thank you so much for joining us today. And maybe please request you to take over the case discussion, please.
Thank you. Thank you so much for this opportunity. A very good evening to all. What a fine lecture by Dr. Fraser. Excellent. So a lot of important points and insights into the management of metastatic RCC. And this disease overall has been such an exciting journey for medical oncologists. So we have seen that era where TKI was not available to using single agent TKI, sunitinib and pazopanib did hold on for approximately, I would say, a decade before the IO era began. And then things have suddenly turned where we are seeing lots and lots of patients going into complete remission and sustaining that for prolonged periods. So let me just share my slide. I think I'm finding it a bit difficult to share my slide. Can you put those slides?
Yeah, Neera, if you can just share the case presentation. Dr. Gupta, will this be preferable for you?
So just to set the context of this current meeting, I'll go through this case presentation. So next slide, please. So here we have a 69-year-old lady who had hematuria. In fact, she underwent nephrectomy few years back in September 2019 for a renal cell carcinoma. Uh, Additionally, there were few comorbidities, including a cardiac comorbidity where ejection fraction was less. It was 35%. She had hypertension and adrenal insufficiency. Now, after a few years, in July 2023, she started complaining of lower back pain, and there was pain which was radiating to both lower limbs. So there was difficulty in walking, and there was generalized weakness. Next slide, please. Right. So evaluation was done. MRI of the lumbar spine was done, followed by a PET-CT scan, which showed that there were certain lesions involving the vertebra, the lumbar spine, and there were few lesions involving other bones, including the scapula as well. A biopsy was done, which confirmed that the morphology was consistent with clear cell renal cell carcinoma. Next slide, please. So, as I said, she had cardiac comorbidity. There was concentric LVH and ejection fraction was 35%. There was a diagnosis with us now that she is having metastatic renal cell carcinoma, which has recurred after a period of around 4 years. So she was started on a combination of avelumab 800 milligram once in 2 weeks and axitinib 5 milligram along with denosumab 120 milligram. Gradually, the general condition of the patient improved, the pain improved, and the overall weakness improved. Next slide, please. Yeah, so we did a repeat PET scan after a few months. Next slide, please. The next slide shows the comparison. Yes, so here we can see as compared to the baseline scan, which was done in July 2023, we see actually there is reduction in the volume as well as in the avidity of the lesion, and which coincided with the clinical improvement as well. Next slide, please. So she continued to receive this combination IO plus TKI, and she continued to derive benefit. In fact, a few months later, metabolic lesions, and so on and so forth. Next slide, please. So patient completed 25 cycles of avelumab 800 milligram once in 2 weeks along with axitinib and denosumab, and she derived a clinical response, and there was response on the scan as well. Next slide, please. So with this, I'll conclude this small short case presentation, and let us move on to the panel discussion now.
Many thanks, Dr. Gupta sir, for that case presentation. Really puts into the data points also into perspective with this case presentation. Moving on, Nirav, if you can just reshare the slides. We will have an interactive panel as the next session which has been planned up. This will be led by Dr. Chandrakant Devisa from Kolkata. Nirav, next slide. Dr. M.V. Chandrakant sir is the academic head and consultant medical oncologist at NH Narayana Super Speciality Hospital from Kolkata. And the topic of discussion is looking at IoTKIs with a close look on the favorable risk group. Dr. Chandrakant sir will be joined by the expert panelist, and may I please invite Dr. Chandrakant sir to invite all the panelists and to take over the proceedings. Dr. Chandrakant sir, over to you.
Thank you, Dr. Harshveer. Just one second.
Harshveer ji, this slide would be continued, or sir wants to share it?
Nirav ji, apna,
I will share.
Dr. Sir will be sharing it. Just keep it online until he shares it, please.
Okay, fine. No issue.
But he will be taking on the screen sharing.
Right. So let me share.
Yes, sir. Please go ahead.
Right. Thank you, Dr. Harshveer, and I would thank Merck for the opportunity. And it's always uh, can you allow to share the screen? Right. Right. So Merck always gives a perspective as to how to read between the lines of data and how to best position the molecules. And it was a wonderful uh, lecture by Dr. Ricky Fraser. A very nice perspective, very clear, very important messages he gave. First chance is the best chance because not all patients go to the subsequent line. Therefore, give the best treatment in the front line. And you need to look favorable risk patients differently. We looked at intermediate poor risks as one category and favorable as one. And we always thought that IO is not required in the favorable subset. This is what the usual thought went on. But after this subgroup analysis and the data, I think we can understand that a favorable risk also benefits with a immunotherapy. So with this in background, so we have panelists are Dr. Fraser is there, and I would request him his expert opinions after asking our panelists. And then we have Dr. Suresh, Dr. Alok, Dr. Shibashish, Dr. Reshma, Dr. Buran, and Dr. Vijay. So I will be going in the same order as it is there in the agenda. Right. So this is the first slide. Just to say that there are 5 treatment options of IOTKI. I mean, 4 IOTKI and 1 IOIO. So 5 important treatment options. So whenever a patient of RCC sits in front of me, I get these 5 options in front of me. IOIO, Nivo-EP was the first, and then came the Pembro-Axi and then the Ave-Axi, the Javelin Renal 101, which we will be talking more in detail here. And then after 2 years, we have Nivo-Cabo and Pembro-Lenva. So this is how the evolution of IOTKIs happened from 2018 to 2021. So now we have all these 5 regimens approved for use. So this is how the trial design is. This included all metastatic clear cell RCC, the Javelin 101 phase 3 trial. So just note the doses. It is 10 milligram per kg of avelumab with axitinib 5 milligram twice daily versus sunitinib. And just note the duration of follow-up. So of course, Nivo-EP has the longer follow-up, but if you look into any IOTKI trial, it's the Ave-Axi trial that has the longest duration of follow-up, that is 73.7 months. Beyond 6 years of follow-up in a IOTKI is something that is to be looked at. If you look into other IOTKIs, they have a shorter follow-up. Even a Pembro-Axi, even though started early, the reported, the follow-up is not that long. This is one more that you need to remember.
Yeah, but
So this is how the curves are separated. You can see early separation of curves. We already saw the presentation by Dr. Fraser. So early and consistent separation, statistically significant difference in progression-free survival, 8.5 versus 13.9. Very important. The delta is 5.4 months improvement in PFS and a 34% reduction. And this is the overall survival. Well, it did not meet the statistical significance. Probably the reasons were said like more porous patients, a lot of subsequent therapy in the sunitinib. So, Dr. Suresh, can I start with you? Dr. Suresh?
Yes, sir, I'm here.
Hi, Dr. Suresh. So, Dr. Suresh, this is the curve in front of you. I will show you in the future curves also. This is how it is, If you follow any of the clinical trials, whether it is Keynote 426, Checkmate 9ER, or the Clear, on a longer follow-up, you see that difference in OS is diminishing over period of time. And if you look into AVAXI, you have the longest follow-up, and therefore there is some diminution. So what do you think is the probable reason why the median OS in the ITT population did not meet statistical significance in Javelin Renal 101?
Yeah. So I think the OS, we should also look at the subsequent treatments. What is the percentage of patients who received a subsequent IO in the sunitinib monotherapy arm? So that is one thing which I would like to see.
Very good. Very important point, as you said, what is the sunitinib doing? That is very important. So, well, if I can request Dr. Fraser.
Yeah, so
Yeah.
I would
So I
I would
was,
you
so
go
I
ahead.
was just, yeah, I was just asking, what are the probable reasons why Javelin Renal 101 did not meet a statistically significant improvement in overall survival? What do you think are the probable reasons?
Yeah, so I completely agree with the last comment, but I also think it's the fact that there was only 20% of the patients in the trial who had favorable risk disease, and so we know those patients do well, and that they're often in terms of the driver of data, they're often the patients with the best response rates, the best PFS, and so again, I just think of the baseline characteristics put this trial at a disadvantage compared to the other trials. And so that's why I don't think we should do cross-trial comparisons, but I do think we need to look at the individual data sets and understand the baseline characteristics and how that will influence the outcomes.
Thank you. Thank you for that wonderful comments. So, well, just to summarize, what are the probable reasons? As an oncologist, what I see is there a statistically significant difference in OS or not? If there is no difference, reflexly, I feel, oh, there is no overall survival difference, then that's not a great regimen. This is the reflex thought that goes in an oncologist's mind. The probable reasons, what Dr. Fraser said, number one is, are the patient population included? Are they similar in all the trials? You have to see what is a percentage or what is the proportion of good risk patient. That is very important. Lesser good risk, greater intermediate poor risk patients in the Javelin renal when compared to the keynote 426. That is number one. Point number two, the sunitinib arm received greater immunotherapy in the subsequent lines. This is number two. So these are some important differences that you need to uh, understand before we say there is no statistically significant difference. But what about the clinical difference? And very importantly, longer the follow-up. You can see the subsequent trials like 4 to 6, 9 are clear. If you follow them up for a longer period of time, that magnitude of OS actually diminishes because the control arm, the sunitinib arm, starts receiving IO in the subsequent lines. So therefore, that delta of difference diminishes. So because of all these three reasons, uh, lesser good risk patients, greater subsequent line therapy in sunitinib arm, and a longer follow-up. Probably these are the reasons why the statistical significance is not met. And we have got clinical experience of AVAXI, how fantastically it does. So there is a lot of difference between the statistical significance is for an approval, is for a statistical approval, but may not reflect an actual clinical practice. Right. So this is what I was saying. Like if you look into the sunitinib is doing well over a period of time, and the OS curves are just sitting on each other. There is absolutely no difference. Right. So this is one important message that we got. Right. So let me next go to Dr. Alok. So Dr. Alok, you looked into the PFS curves, you looked into the response rates, and in terms of 12 months OS rates and OS curves, I'll just take you here. The landmark OS at 12 months, checkmate 214 versus Javelin Renal 101. So your comments on this, Dr. Alok.
So,
We have Dr. Alok? Yeah.
yeah,
Yes, sir.
across all these trials, we see a class effect of the combination strategy and the magnitude of improvement at 12-month OS. But we see somewhere around 10% across and 10% absolute benefit in 12-month OS, what we see across all these studies. So certainly the combination appears to be more active at 12 months and maybe even for the initial 3, 4, 5 years. Beyond that, there is something which is happening and has been discussed by you that the curves are meeting again. But certainly at 12 months, the combination strategy does helps, and it shows that it helps in saving more lives.
Right. Fantastic. Again, 1 year it's working fantastically, but on longer follow-up it is not. That is because of subsequent therapy in the control arm. Right. So this is one more. So I will go to Dr. Shibashish. So do you agree with the ASCO guideline recommendations of IO-TKI combination in all risk? Anyway, for intermediate and poor risk, yes, we are giving IO-TKI. What about good risk? I think Dr. Fraser showed a fantastic data, the real world data. This is the data that he showed. Really very important data that even if you treat a favorable risk patient with the IO-TKI versus TKI alone, there is significant reduction in the risk of death and also progression. And second important point, 50% of patients will not receive second line therapy. So because of these two reasons, Dr. Shibashish, do you feel that all risk patients should receive immunotherapy with TKI, even in the favorable risk? Yes, sir. Dr. Shivashish?
Sir,
Okay.
you need to unmute yourself. Bhattacharya sir, please unmute yourself.
Yes.
Yeah,
Am
now
I
yes.
audible?
Yes.
Actually, this specifically showed working best in the favorable risk group. Favorable
Right.
risk group in real world also has shown that it works best, this combination,
Right.
Ave and axitinib.
Right, sir.
Avelumab.
Right, sir. Right, sir. Thank you. Thank you for your input. So again, so very importantly, our thought that IO-TKI combination may not benefit in favorable risk. This is the thought we had, but this is one real world data that is clearly showing an IO-TKI is superior to TKI alone, even in the favorable risk. And these are the different regimens that you have. So the thought that why a favorable risk should receive only TKI was based on these studies. I think we had a very fantastic explanation by Dr. Fraser, saying that the toxicity to efficacy benefit is what matters. Avaxi is one of the best tolerated regimens, one of the least toxic regimens. So when you have a least toxic regimen with a good activity, that is when uh, the balance shift towards an IO-TKI. So if you look into keynote 426, 9ER clear, all of these trials, the favorable risk is not getting benefited with IO-TKI combination, and this is how it is. So the hazard ratio is with Pembrolizumab is 1.1, with 9ER as 1.1, clear as 0.94, and with Nevo EP anyways, it was not significant, is 0.82, and the hazard ratio is best with the Javelin Renal 101. I think this is the slide of the day today. So I will go to Dr. Reshma. Dr. Reshma,
Yes, sir.
this is the slide of the day. So previously we had a thought that good risk TKI is enough, but here we go. TKI is not enough. We showed the previous two slides, and this is the Javelin Renal 101 in good risk. So your take on good risk in the present day.
So the slide which you have shown, I think the best HR is what we are, directly the data is pointing towards Javelin that it has the best HR of 0.7. In fact, the checkmate is in fact showing a negative 1.1. Keynote is in fact showing a little negative. So with this data, I think the Axitinib Avelumab, we are comfortable using it in the favorable group. And also clinically, we are very comfortable using this combination. It's least toxic and does well with a good it will have good results with a very good the quality of life and less side effects.
Right, right. So can I request Dr. Fraser? So, sir, why do you think Avaxi has outperformed other IOTKI or IO combinations in favorable group? Why do you think the difference is marked in Javelin Renal 101?
Yeah, great question. I think there's a biological rationale. So I think the PDL1 story works for this. So I think we're still understanding what natural killer cells do, but they're certainly going to have a role in that microenvironment in T cell trafficking and interacting in T cells. So I think there's that. I think also, Exitinib is a very nice drug to be able to titrate through, and particularly in favorable risk, where you want to, there are patients who've got relatively low burdens of disease who don't, you don't want to be risking them having that, severe toxicity, in my opinion, from something like 20 milligrams of lenvatinib. And so for me, it's just the data tells us. So that's why I think it's important, is it's not just an opinion piece. If we're following data and we spend the rest of our lives following data, it's the strongest data. It's the strongest data. It's got a biological rationale. So for me, it's debunking the idea that we think we know what the data shows. It's actually shining a light on really what does the data show, and the data shows best response rate for Axiavi, best hazard ratio for Axiavi, longest follow-up for Axiavi. So Axiavi is what I would do.
Fantastic points, Dr. Fraser. I think what you mentioned in the last 1 minute is the take home for all of us today. So, point number one, favorable risk. A TKI alone is not enough. Number two, 50% of patients do not receive second line. Point number three, there is a significant biological rationale of a PDL1 inhibition in the favorable risk. More to know, but this is what we know right now. And this is the data in front of you, specifically looking at favorable subset. The hazard ratio is best for Javelin Renal 101. And two reasons. One is the biological rationale of the natural killer cells and the PDL1 doing something there. And number two, the least toxic regimen. Like Avelumab is easy, like even in a patient with hemodialysis, you can give it. Has least pneumonitis, as you were mentioning before. And Axitinib has the shortest half-life, which can be easily managed. So because of less toxic and a more efficacious regimen, especially in the favorable risk, and that is why you are seeing these impressive hazard ratios in this. I think this is something practice changing. So Dr. Buran, can I request you to comment? Dr. Buran?
Yes, sir.
So, I mean, you saw this excellent results in the subset of favorable risk. You think this is practice changing in the next day morning if you have a patient a favorable risk? Would you consider Avaxi as one of the regimen that you have to counsel the patient?
Yes, I think as you rightly pointed out, there is a interesting data, and the hazard ratio is quite impressive as far as the favorable risk is concerned. And also, we know that many patients, almost 50% of patients, might not be receiving the IO in the second line and beyond setting. So that is something to consider, and that is something to actually we should counsel our patients once we are selecting the treatment in the first line therapy. So definitely I will consider the IO as well the TKI combination, especially the Axitinib with Avelumab in the favorable subset.
Thank you, Dr. Buran. I think Dr. Fraser already has conveyed the message that we all need to receive. And this is the spectrum Good risk, favorable risk is more VEGF, and poor risk is more IO. So even in the poor risk, so just to mention, we just had a real world case series report of around 9 patients of Avaxi. In that, 5 patients were poor risk, and all of them have done extremely well in the poor risk. So poor risk also, the hazard ratio is something fantastic. You cannot uh, ignore it. And good risk, it is doing really well. So
So,
my
Dr.
experience,
Chandrakar, I just sorry to interrupt you.
yes,
I
Dr.
just
Buran.
want to know, if you can ask Dr. Fraser that why it did not help the intermediate risk. So, what
Right,
has been the problem over? Because that is the only subgroup that has not shown the benefit.
right,
So, what
right,
is your take on that?
right. I was just
Yeah.
about to ask him. Right. Yeah, yes, sir, you can answer.
Yeah, no, it's a great question. And I don't think we know the answer to that question. So, we know that intermediate is a very heterogeneous group.
Right.
We know that the interplay between VEGF and the microenvironment is complex. And my feeling in this group is that this is maybe where the other receptors become important. So being able to target MET, being able to target PDGFR. And so I think for me, because it's a more sort of complex environment, I think having different receptors being targeted by a TKI may be adding value here. And interestingly, if we look at Cosmic 313, which is, there's an update being presented today, the triplet regime, that actually didn't do very well in the poorest patients where we expected it to do well. And so again, that doesn't make a great deal of sense. But for me, it's probably something in the receptors and the mechanism within that fairly heterogeneous intermediate risk group.
Again, great thoughts, Dr. Fraser. I mean, intermediate risk is a large subset, and that's not a single subset. You have different subsets among the intermediate risk. So because of this heterogeneity, probably we are not able to clearly say who benefits more with TKI, who benefits with multi-tyrosine kinase inhibitor. So it's a heterogeneous subset, and we need to know more about the intermediate risk. That is what we can understand. Right. So this is the overall survival in the poor risk. The hazard ratio is fantastic, 0.58. And this is how the curves looks like. As Dr. Burhan was pointing out, favorable and poor risk, Avaxi has done extremely well. One of the best hazard ratios in the poor risk, 0.58. No other trial is specifically addressing the poor risk. Avaxi has specifically looked into the poor risk. So, Dr. Vijay?
Yes, sir.
Yeah, Dr.
Good
Vijay.
evening.
So, there is the data in front of you for favorable and poor risk. So, for favorable risk, you've seen that no other trial has got such wonderful hazard ratios. So, what is your opinion on the poor risk subset? Are you comfortable offering Avaxi to this subset?
Yeah, as Dr. Fraser had mentioned, I think it is important that we don't lose these patients in the first few months or in the first few years of therapy to a progressive disease, and they may not come up for the second line. So, if I have a patient with poor risk, IMDC poor risk in front of me, my primary concern is that this particular patient may probably progress quick. So, my concern is that he should not progress quickly. And I think a combination of TK and IO would probably be the best way to go forward, just with the intention that he should not lose this patient to an early progression.
Right. I think Dr. Vijay made very valid points. In India, what are the types of patients we see? If a patient is poor risk in India, they've got a heavy disease burden, and we want a response in coming 3 months. So if I give IO, I have a 30% chance that he will have disease progression as the best response in the first 3 months. And therefore, offering IO in the poor risk is a challenge for me, because I will have 1/4 of patients just progressing in the first 3 months. That is a risk that I have. And number two, our patients are more frail. They are like performance status 1, 2, and they have some compromised organ function. So to give a cabozantinib of 40 milligram or a lenvatinib of 18 milligrams or above, it's impossible in our practice. So it's not easy to offer new cabo or lenva in that high doses to poorest patients who are frail. So it's very meaningful to give a regimen that has a smooth induction in the initial 3 months, stabilize the patient, the performance status improves, and he should not have progression as the best response. So axitinib is one of the preferred TK, as Dr. Fraser was mentioning, shortest half-life. You want to have only VEGF activity. So that is what is the importance.
Sir, I would like to ask a question to Dr. Fraser. If it
Right.
was a sarcomatoid variant, and let us say it is IMDC poorest, would we prefer a IO or would we still prefer IO TKI?
Yeah, great question. So we presented some data at ASCO this year showing that IO-TKI is very effective for sarcomatoid. So we know IO is effective, but in the real world, it was a comparable data set for IO-TKI in the sarcomatoid. So what do I do in real life? If somebody has got relatively stable disease, then I will try and give them IO if there's a large sarcomatoid component. If I'm worried about disease progression, I would still give them an IO-TKI base, because we know even with single agent IO, patients do really, really well in the sarcomatoid group. And just to kind of add to that, the point that was made earlier about the exitinib, I think the other thing people forget about exitinib is escalating after 2 weeks to 7 milligrams twice a day, and then to 10 milligrams twice a day after another 2 weeks. And so the idea that you can't get people onto a decent dose of Axiavi just isn't the case. But I think sometimes in the real world, we forget that escalation and we find ourselves 2 months down the line still on 5 milligrams of exitinib. And so I really like the 5, 7, 10 approach, because patients get really comfortable with it quickly, in the way that I personally find it's not as easy to kind of go up through the ranges of lenvatinib. And with cabo, I never have the option to give them 60 milligrams of cabo, because in the frontline space, you can only give 40. That's the licensed dose. So I really like the, let's give you 5, it's going well, let's get to 7, it's going well, let's get to 10.
I think very important points, like the flexibility of escalating the dose is fantastic with axitinib, and we can monitor them slowly. You can have a very smooth induction in the initial couple of months. So that is a very important point. Right. So I'll be back to Dr. Suresh. So Dr. Suresh, so this is important. When I'm giving IO TKI, if there is diarrhea, we don't know whether it's an IO diarrhea or a TKI diarrhea. If I stop axitinib, the diarrhea just reverses very quickly. Whereas if it's cabo diarrhea, it's going to, the cabo has a very long half-life, and diarrhea is going to continue. So it's a challenge, to manage a IO-TKI diarrhea. If it's axi, it's easier. So your thoughts on the preferred TKI in combination with IO in RCC, Dr. Suresh?
Yeah, so definitely, as Dr. Fraser has said, so axitinib, I think, would be the best possible combination with IO, because it has a very short half-life, around 4 to 6 hours. So I think in case of any toxicities, just by stopping the TK, we can expect quite rapid reversal of toxicities if it is due to TKI.
Right.
I think it'll be easier if you have given axitinib than the other TK goes under.
Right. So if you have a toxicity, it's going to be quickly reversed by stopping axitinib. So that is the key of using axitinib. And if it's cabo, I've got a patient of Nivo cabo. So I stopped cabo. The diarrhea didn't reverse. So I thought it's probably due to cabo, and I went on treating conservatively. And the patient continued to have diarrhea. Then I did a colonoscopy at the end of a week, and then I found a lot of ulcers that were immune related. So I just cannot understand whether it is a cabo diarrhea or it's a Nivo diarrhea. So it's not easy to manage the side effect of a cabo based combination. So whereas with axitinib, it's easy because it's the spectrum is narrow. It's just VEGF plus the half-life is short, right? Yes, Dr. Fraser, you were able to say something?
Yeah, so just on the diarrhea story with TKIs, again, I've learned this the hard way, and we cover it in one of our podcasts, that it's really important we don't just assume that diarrhea is TKI related. So the three things that I always think about before I blame the TKI is, has this patient got pancreatic insufficiency, and therefore I always do a fecal elastase? Has this patient got bile acid malabsorption? And there's a couple of different capsule tests that you can do for that. And do I think this patient might have bacterial overgrowth or be on a PPI? And so it's really important. So I've had a number of patients where I've been going up and down on doses with not a great response. I check a fecal elastase, it comes back at 100. I give them some Creon, the diarrhea resolves, and they can go back to top dose. So it's just important to remember not just to go, this must be TKI. We know that, for example, some of the TKIs target fibroblast growth factor, and we know that that's one of the receptors that causes bile acid malabsorption. So really important just to think a little bit more laterally when you see diarrhea.
Right, right. Again, great points. I at least didn't investigate exhaustively. I think fecal elastase is a very important test that we are supposed to do. Right. Thank you for sharing that. So I think this we already discussed. The PFS difference, the delta is better with Javelin when compared to Keynote 426. The separation is fantastic. The delta is greater. And then this is uh, IO-AXI comparison between the two. So, Dr. Alok, you want to just have a comparison, not a cross-trial comparison, just looking into the data. Yeah, Dr. Alok, your take on this, AVE-AXI versus Pembro-AXI.
So I mean, the essentially curves look similarly moving. There is very less difference between these two select if one is superior. Although numerically, if you look at Pembro exit, the median is reaching 47 months, and Avelumab exitinib it is around 45 months. So there is hardly anything to select between the two. However, as you said, the delta improvement over and above sunitinib appears to be larger here. Response rates are also exactly same, 60%, and median OS benefit is also it also appears to be same.
Right. And more importantly, if you look, the follow-up is longer with AVE-AXI. The percentage of favorable patients is higher in the Pembro-AXI. So a good subset of patients are there in the Pembro-AXI. And then the discontinuation rates are very important, like greater discontinuation rates, the pneumonitis rates are higher, and the chances of using a steroid, that's also almost double in the Pembro-AXI. So definitely Pembro-AXI has a uh, greater toxicity, greater discontinuation rate when compared to AVE-AXI. So this is what you can understand. And the PFS delta is also better with AVE-AXI. So this is a very finer look into the data, but this is what we have. Right. So dialysis. Okay. So this is some small 3-patient study of using in papillary RCC, acquired cystic disease RCC, and also clear cell RCC with those patients who are on dialysis, end-stage renal disease patients with the RCC successfully treated with AVE-AXI regimen. So this is something I was mentioning, that AVE-AXI is fantastic and I can use. So, well, with this opportunity, I'll just ask Dr. Fraser one question. So, Dr. Fraser, so in HCC, I've used IO post-transplant, like I've used pembrolizumab post-transplant. I mean, a couple of patients didn't have a graft rejection. So now I'm supposed to use another RCC who is post-renal transplant. So, I mean, this patient has a NSCLC and I want to use IO. So, I mean, out of the way, I'm just asking you, your take on using immunotherapy molecules in a patient who underwent renal transplant. Any experience? What are your thoughts in this niche space?
Yeah, so I've got a large cohort of patients that I manage who've got liver transplants, renal transplants, one who's had a lung transplant. So I treat cutaneous squamous, so a lot of those patients have transplants. I find that the vast majority, so what do I say to patients? I say on average, the chance of losing your kidney is probably 1 in 3. So I do prepare them for that, for patients who've got transplants. What I follow is so there's a trial called Contact One, which was led by Glenn Hanna, who's an oncologist, head and neck oncologist in the States. And in fact, we had Glenn on one of our podcasts, and he talks about using essentially an mTOR alongside pulsed prednisolone. And so that's what I do for all my transplant patients, is I convert them to essentially sirolimus and pulsed pred. And touch wood, I haven't lost any transplants, and I've probably managed 15 patients with transplants now. So again, if you've ever got a patient, very happy to talk it through with anybody via email. And again, there's a podcast if anyone wants to just understand how that trial's informed my practice.
Fantastic, fantastic, Dr. Digi. This gives a lot of confidence in using in our patients too. Really, I would reach you out for this and I would watch the podcast. Great thoughts. Right. So now, again, just to quickly go forward, and we saw the toxicity profile, of Avaxi versus others, and the steroid use. I think this is how the steroid use is all about. Like with Avaxi, it is 14.5. With all others, it's like 35% with Nivo-EP. The pneumonitis rate is very high with Nivo-EP and Pemroaxi. So the toxicity profile is definitely better with Avaxi. So Dr. Shubhashish, do you have? Okay. Then Dr. Reshma.
Yes, tell me.
Yes, sir. So, sir, this is the on the screen you have the toxicity profile of the 5 regimens. So what you can note is the steroid use has been least with Avaxi. Again, the dose discontinuation is also least. The pneumonitis is least. So looking into the toxicity profile, do you feel avelumab axitinib is a favorable regimen?
So here, very less number of favorable risk and more poor risk compared to the only competitor, that is the Pembro plus Axi group. So I
Right.
think there it was 32% favorable group.
Right.
So I think it scores above the Pembro plus Axi. And corticosteroid usage is also not much in the Javelin trial set.
Right. Thank you, sir. Thank you. So I think that's what we understood, that it is safer to explore and navigate through Avaxium compared to other regimens. Dose discontinuation is also better, and this is some data suggesting that PD-1 inhibitors are more toxic than PDL-1 inhibitors in terms of pneumonitis and sarcoidosis and so on. Right. So, Dr. Fraser, you want to share some thoughts on the toxicity profile of PD-1 versus PDL-1 in this subset, in this space?
Yeah, I mean, for me, there's no doubt about this data. It's really powerful. And ultimately, we want to keep our patients on treatments, don't we? So, the fact that we're using less steroid, and we know increasingly we're looking at data that shows, if you put somebody on a tapering dose of high-dose steroids, about 4% of patients will become long-term adrenal insufficient, even if they weren't before they started the high-dose steroids. We know that it causes weight gain, increases blood pressure, which is already a challenge in our patient group, and we simply don't know the impact on efficacy yet of high-dose steroids. So for me, anything that can lower the rate of toxicity, that lowers the risk of life-threatening grade 3-4 toxicity, is a win. And so for me, the numbers speak for themselves.
Thank you, sir. Thank you. So I think we had a question in the chat box for you, Dr. Fraser. So the question is this about IO re-challenge. I mean, two things. One is continuing IO beyond IO, like we had TiNivo2 addressing this. And the other one is IO re-challenge, like you had some IO free interval in between and again giving IO in the third line setting. So your thoughts on both continuing IO beyond IO and IO re-challenge after some IO free period.
Yeah, no, that's a great question. So, as the audience will know, that we've got two main trials. We've got Contact 3 that looked at Cabo and Atezo, and we've got TiNivo 2, which looked at Nivo and Tivo. Neither of those trials were great trials, in my opinion. Tivo dose was wrong in the combo arm, and Cabo did really well in Contact 03. So what do I believe without, without a great deal of data is, I treat melanoma and I give second opinions on a lot of IO in lots of different spaces. I think there is definitely going to be a role for re-challenge. I think we haven't worked out quite the right group yet, and we'll probably need to use, tumor mutational burden, PDL1, other predictive algorithms, ctDNA, biomarkers to work out who are the right patients. As of today, we haven't got strong data to do it, but I find it difficult to believe that renal will be so different to any other tumor. I think we just haven't done the right studies. So if this is my relative tomorrow and they've had a PD-1 or PDL1 in the front line, would I give them more immunotherapy? Absolutely. And particularly if I gave them a break off immunotherapy, I think there will be a group of patients. If we look at mechanistically, the T cell occupancy is about 6 months after you stop immunotherapy. And so I believe after that, there will be a degree of patients who there will be a resensitization of the immune system. And what I think will happen with time is we'll find other ways to stimulate that immune response. So it may be the microbiome, it may be other things. But I think at the moment, we've just got two trials that weren't done in the right way.
Great thoughts. I think you add a lot of value. 6 months is the period that we'd look into, and you would consider re-challenge if there is a good IO free interval. If a patient is on IO, giving a subsequent IO is not that meaningful. But if you have an immune free interval of 6 months around, that's the patient that you would give. Great thoughts again. A lot of learning. Right. So, Dr. Reshma, I would ask you regarding use of Avaxi in frail patients. Like, you saw someone like dialysis, and this is one more data of AKI along with immune checkpoint inhibitor. So, your thoughts on these difficult to treat patients of this Avaxi combination?
So even if the patient is on dialysis, like ESRD patients developing RCC, I think Keytruda and Evolumab are safe. They are high molecular weight compounds. They are not really dialysable, and have used in one or two odd patients, and did not need to reduce any dose. Patient has tolerated, did not have any increased risk of any toxicity. So even if the patient is on dialysis, I think use of Evolumab is safe. And risk of AKI. So recently, actually, I just want to share one experience. Recently, I've used this Keytruda axitinib combination in one of the patients, very healthy, otherwise not comorbid, elderly male. But then he started developing a rising creat, and I thought let's stop axitinib first, but it didn't resolve. In fact, it went on rising, and then stopped Keytruda. Still, it has not really settled. The creat is still on the higher side, so it is some sort of renal injury was definitely there, and eventually the patient is now still, I've kept it under observation, not really introduced any other molecule. So some of the other unusual toxicities we do see, but like you said, the frail patient on ESRD, I think immunotherapy is safe.
Right, right. And you have seen the data of Avaxi, the slides where
Yes,
in
yes.
all the subsets they have used Avaxi. Right. So great thoughts. Thank you, Dr. Reshma. Dr. Buran, the next day morning, which patients do you want to offer Evolumab axitinib in your practice? Dr. Buran?
No, I believe Dr. Boran had some technical issue.
Right. Then I will go to Dr. Vijay. Dr. Vijay is there?
Dr. Vijay is there. Dr. Vijay, if you can.
Sorry, sir. Yeah, so I think there is a case to use the combination in almost
all the risk groups, and especially particularly if I have a frail patient in front of me, I think that is where I would preferentially use this combination over any other regimen. And especially, I have a couple of patients. In fact, most of my experience with this combination is in fact in elderly more than 80 years, and actually all of them have tolerated the combination well, even without requiring any dose reductions for axitinib. So it's a very smooth and gentle regimen to use.
Thank you, Dr. Vijay. So let me summarize and then I will again take thoughts from Dr. Fraser. So this is the summary that's there on the screen. Advanced renal cell carcinoma, favorable risk, IOTK is the way to go, and AVE-AXI is the regimen that has shown the best hazard ratios. Even the poor risk has benefited fantastically with the hazard ratio of 0.5. It is the most safe with least steroid use and least discontinuation, and therefore metastatic RCC is a heterogeneous disease, and in good and in favorable risk should be looked favorably, and the poor risk also AVE-AXI is done well. And those patients who are sarcomatoid or ESRD dialysis, also you can use AVE-AXI. So, well, I would now request Dr. Fraser to have his comments, the final thoughts, and also to answer the question in the chat box.
Yeah, I'd be delighted. So, in terms of the answer, so the microbiome question is a great question. So we know that the microbiome story is really strong. We know that in renal cancer, CBM 588, which is Clostridium butyricum, looks really good. There's a number of data sets now, both in combo IO, but also in IO-TKI and single agent TKI showing activity. And we think that's essentially driving butyrate production, which is a driver for T cells. In terms of microbiome transplants, I think there's definitely going to be a role for that in future. There's some data, particularly in the melanoma space, of transferring the microbiome from a responder to a non-responder and converting them to a responder. I've also used microbiome to treat refractory colitis, and I found that to be very effective. So to answer the question, yes, I think it's something to definitely consider. I think, and also just some simple tips. So we were very lucky. We had Georgina Long's group from Australia come on and talk about the microbiome on the podcast. And so some of the really important messages that I would recommend that I do in clinical practice is I stop all PPIs in patients starting IO. And if they need something for acid, I put them on to a H2 antagonist. There's really strong now data to say that PPIs increase your risk of AKI, which is relevant for the last case, but also decrease the effectiveness of IO. I try and avoid antibiotics in the first few weeks, again, because the impact on the microbiome. And I tell my patients to eat a varied diet with high fiber, because there's really good data that it increases organisms like ruminococci, which seem to be quite effective. So in essence, microbiome, what's this space? It's going to be a really important space in the next few months and years to come.
Thank you, Dr. Fraser. I think a lot of learning, and we would look forward to hear the podcast and a lot of learning from you. So thank you once again. Thanks all the panelists for their active contribution. Thanks, Merck, for giving us the opportunity to learn. Yeah, Dr. Harshveer, over to you.
Thank you so much, Chandrakant sir. So with that, and we are also right on time. Thanks to all the faculty for that insightful discussions, the keynote lecture. With that, while I'll be giving the thank you, but just as a reminder to all the live audience, so faculty, we have had close to more than 100 live audience. Some of the questions have also come in that you have answered. Thank you for doing that. Just a reminder to all the audience, while we at Merck will be continuing to deliver scientific communications accordingly, but these were some educational resources that Dr. Fraser and the group are delivering. Please utilize them as you all deem feasible. Um, Once again, thank you to the live audience. There is also a feedback form which is also available on the website. So if you all can please fill in that feedback, that will be helpful for us to also deliver our scientific meetings accordingly. A special thanks to our international expert, Dr. Fraser, maybe a more friend for India. second time that he has accepted our invitation, and he has a long day ahead today because he's also participating at ASCO GU. Started his day quite early. Thank you, Dr. Fraser, once more for the active participation, the great lecture, and the insights during the panel discussion. Dr. Alok Gupta sir for the case presentation and also participating. Dr. Chandrakant sir for leading that active, interactive, and insightful panel discussion involving all the panel members greatly. Dr. Chandrakant sir, thank you so much. And of course, our other panelists, Dr. Suresh Kumar sir, Dr. Subhashish Bhattacharya, Dr. Reshma Puranik, Dr. Puranwani, and Dr. Vijay Sima for their participation. Dr. Rawal sir began the meeting very well with his chairman's lecture, and of course he couldn't be a part of the last session, but thank you, Dr. Rawal sir, for being a part of this meeting. With that, once again, thank you so much, faculty, and thank you so much to all the audience for joining us today. Have a good day. And Dr. Fraser, we look forward to some more insights coming in from ASCO GU and more educational meetings in the coming time.
I'd be delighted. Lovely to see you all.
Thank you so much. Good day and good night.